Rubin is a Bronx boy to begin with.
That's true. That's true.
That's his best credential.
That is absolutely
Otherwise, he went to Yale Medical School, did his medical residency at Cornell, New York Hospital, did his GI fellowship at Columbia, and is now doing research at Columbia, and at the same time is chief of gastroenterology at New York Hospital, Queens. I will give you his phone number later if you need a colonoscopy. He's going to be speaking here tonight about reflux disease and other items. Please feel free when he's done to ask him any questions about gastroenterology, and he will be able to answer them.
Well, it's a real treat. I don't think I've ever spoken in a shul about gastroenterology. So this is a first for me, and thank you very much, Dr. Bright, for inviting me and thinking of me. I actually spoke to Dr. Bright about the talk, and there are two talks that I thought about giving. And we're going to have some audience participation to decide which one you really want to hear first, because you're going to get tired after I talk for a while. The first subject is reflux disease, which is a very common malady that affects many, many people. And the second talk is about something that, which way?
No.
Thank you.
Okay.
I see myself, okay. The second talk, I'm going to just disappear. The second talk is about a topic which I've been involved in some research over the years. It's called Clostridia difficile, which is a very dangerous infection that many people are acquiring both in and out of the hospital. It's a little bit more esoteric. So I can speak about both of these, or I can focus on one or the other. So if you'd like to hear more about reflux, rather than Clostridia difficile, just raise your hand. Okay, and that's what we're going to do. You're going to change the slides for me?
Yeah.
Okay, so we can go to the next slide. So reflux is not new. Since the early days, I have to stand here.
Yeah.
I just look at myself on the screen. Since the early days of recorded medical history, we've been aware of this idea that people get heartburn. Very common complaint, even back in the time of the Beis Hamikdash. I have to say AD year, but it's, well, right after the Beis Hamikdash, anyway.
That's fine.
So Winkelstein, in the modern era, first described what is called peptic esophagitis, when people began actually looking into why people get the types of symptoms they do. And a fellow named Bernstein came up with a test where he would drip hydrochloric acid into people's esophaguses to see if it hurt. And if it did, he said, you must have reflux. And believe it or not, this was called the Bernstein test, and was still in existence up until the time that I went to medical school, which was in the 80s. We don't do that anymore. So we no longer drip hydrochloric acid in. We use other means of identifying whether someone is suffering from reflux. So we can go to the next slide. So I don't know how familiar you are with anatomy, but this is a picture of the top of the stomach sliced. So you're looking inside the stomach. It's a depiction. This is the esophagus. This is the diaphragm. So your esophagus comes down here. The diaphragm separates the chest and the abdomen. And the diaphragm squeezes the low end of the esophagus. And there's also the muscle of the diaphragm. And there's also intrinsic muscles in the esophagus itself. So all of this is to explain that when we swallow, food has to make its way down into the stomach. And the esophagus is actually an active, living, rhythmic tube. It's not just a pipe. And it peristalsis, or has a series of contractions, brings food down, it reaches this valve, the valve opens, all in rhythm, and everything has to be in rhythm in the body, and then the food drops into the stomach, and then the valve closes. And the valve has to close because the esophagus, which is the passageway, is not meant to be exposed to the fluids that live in the stomach. The fluids that live in the stomach are actually highly acidic, and could burn the esophagus. So fortunately, we have this valve called the gastroesophageal junction, or the lower esophageal sphincter. So GERD, or reflux, or gastroesophageal reflux disease, or as you would know it as heartburn, is what occurs when that valve releases or opens, not when you're swallowing food, but when you just have lots of acids in your stomach. And because the stomach is so busy squeezing and contracting, acids reflux up and burn your esophagus. So this is the problem. This is why people get heartburn. Till 8:30, I think. We'll go? Okay. All right. So now, a little bit of reflux is normal. Too much reflux becomes a disease. So everybody has a little reflux. But when it becomes an actual disease is when it happens so often that damage can occur. We'll go to the next slide. And there's different things that can happen when acid begins damaging the low end of the esophagus. You can have normal appearance of the esophagus, but just a lot of symptoms. You can have ulcers form at the low end of the esophagus. So when you have heartburn all the time, it may not just be heartburn, you may actually have an ulcer down there. And it also can cause changes to the lining of the esophagus that we call Barrett's, which turns the normal tissue of the esophagus into precancerous tissue. And what happens actually is the body, this is a good way of understanding it, in its efforts to protect itself, begins growing an abnormal lining in the esophagus, which is great, except that abnormal lining is one step towards cancer. And so that's why untreated reflux can lead to cancer, which is why if you go to a gastroenterologist or your internist or your family doctor or whoever you go to and you say, I have reflux all the time, they're going to get you scoped. They're going to have you have an endoscopy. And it's not because they don't know you have heartburn, it's because they want to see if you're heading down that path, because there are things we can do about it. Okay. So this is what damage to the esophagus can look like. Doesn't project real well, but these are little ulcers. That's a narrowing from scarring. This is the Barrett's. These little reddish tongues of tissue. This is the normal pearly white tissue of the esophagus. And this is what happens to 5 to 10% of people with chronic reflux. And then this is the worst case scenario, is this turns into that, which is a growth or cancer, which obviously you never want to see, because as good as we are in medicine, we're not always good at treating every particular tumor. So here's our typical patient with reflux. And one of the theories about why we're having so much more reflux symptoms now than we did in the past is because we eat really well. And it's not clear that in the past everybody ate this way and didn't exercise very much and ate very high-fat diets. I mean, thank God we live in a society where we have plenty, and, who doesn't like eating well? So there's a lot of reflux, and, we'll go to the next slide. And obviously this not only affects people's health, in the age of, I don't even want to talk about care, but in the age of, money being all important in terms of healthcare dollars, there's a lot of healthcare dollars that are expended in treating reflux disease. Very important topic. Okay. Now it's interesting that reflux affects different societies in different percentages. So this is just a graph of how common reflux symptoms are in the US, in Europe, and in Asia. And it's not because our DNA is different in the US, because the US is made up of immigrants from all over the world. This has a lot to do with the richness of our diet and our lifestyle. And I guess we're eating a lot better than Europeans. Another very interesting thing is I often see patients who say, well, I used to have heartburn. I don't need to take any medicine anymore because I don't have heartburn anymore. Well, that could be good, or it could just be, you're getting tapped on the shoulder. I saw that. That could be good, or it could just mean that you're following this curve, which shows that as people get older and they have reflux longer, they stop feeling the symptoms. So that does not mean you're not refluxing or that you stop making acid in your stomach. It just means once you have reflux, you always have reflux. And that's an important point, which isn't on a slide. Reflux doesn't go away. It's a weakness in the valve, and I'll have a bunch of slides showing you what happens to the valve, which isn't all that important for, you know, a group of people who want to learn about this, but maybe more important for people who do research. But what is important to know is that once that valve is shot, or once you get a hiatus hernia, you are refluxing forever. So a lot of people say, well, you know, I don't want to take the medicine, there are side effects. Then we should talk about alternatives to the medicine because the reflux isn't gone. Okay? So we'll do the next slide. It's just more demographics, you know, that ulcer disease, interestingly, is on its way down. So if we were giving a talk 30 years ago, this wouldn't be the topic of interest, this would be. And now, ulcer disease is declining from the 1970s, and reflux is going up. And it's, you know, not 100% clear why that switch has been occurring, but one possible explanation is in the next slide. We'll go to the next one. These are just fancy slide things. So one of the things we think that's contributing to this is we've been on a tear in modern medicine to get rid of this infection called H. pylori. Any of you hear of H. pylori? Yeah, very common. So if you got scoped, you know about H. pylori. Now, Helicobacter pylori is a bacteria, lives in the lining of the stomach, irritates the stomach, and sets you up for ulcers. So you got to treat it. Not only does it set you up for ulcers, in certain parts of the world, it sets you up for the potential to get stomach cancer. So obviously, once we discovered it, we started treating it, and people stopped getting ulcers, and hopefully we'll get less stomach cancer. Unfortunately, when you treat this infection, you allow the stomach to make even more acid, because now it's even stronger and healthier than it did when you had the infection. So one of the theories is we're getting rid of all the H. pylori, which was protective against reflux, and now you're enabling the stomach to produce too much acid, and you have too much reflux. It's a theory, it's not proven. So we could probably skip, we'll talk about some of this. Other issues that are contributing to reflux is being overweight, and more hiatus hernias are being recognized. And when you're overweight, you're predisposed to a hernia, and you also have more pressure in the abdomen. I don't know if you understand the concept of pressure, but think of blowing up a balloon, or a pregnant woman. You know, pregnant women have terrible reflux problems. Part of it is due to the hormones they produce, which relaxes the muscle. But part of it is just everything is like under pressure in the abdomen because everything's squeezed real tight. So if you're very, very heavy, you have more pressure pushing up on the stomach. You tend to develop a hiatus hernia, and you also have more pressure pushing up acids. Okay. So we can go, you have to click a few times. We're gonna have to, this works better on a Mac. So there's offense versus defense, and we can go to the next slide. And I can really just run through this. Basically, you can do the next one. The next one. Okay. So our body has this gastroesophageal junction to protect against reflux. And we also have the ability to swallow saliva and clear the acids out of the esophagus that get there inappropriately. And then finally, we have the lining of our esophagus can protect itself somewhat to acid. So ending up with, with damaged esophagus is a result of an imbalance between these protective mechanisms and the amount of acid that's coming up and irritating. So we are overwhelming the barrier, the ability to clear, and we're overwhelming the mucosal defense. Mucosa means the lining of the esophagus. Some of this may get technical, but I'm going to breeze through it. You can go to the next one. So here is the barrier. We showed you this in one of the earlier slides. This is an even nicer picture of the same thing. You have the diaphragm, which is just a big, flat, pancake-like muscle with a little hole in it that allows the esophagus to go through. And it pushes and pulls and pushes and pulls and keeps this closed when it's supposed to be closed. And here there's an extra muscle layer in the ring that goes like this that keeps things tight. So that's the barrier. Okay, you can go next. You also have some control from the brain, which is poorly understood about making that barrier work better. And by the way, one of the reasons that stress contributes to heartburn is that last slide. So out of all the things that people say, it's just stress, reflux is definitely related to stress in some people. If you're predisposed to it and you're under stress, there are definitely signals that relax that gastroesophageal junction, increase acid production, increase stomach squeezing, and you get more heartburn. Sometimes if I don't even realize something upset me and I just start feeling heartburn, I say, oh, something must be going on. And then I think, which kid am I upset with? Or, what did the hospital do to me today? Whatever. Okay, so let's go to the next one. So there are definitely, effects. We'll go to the next one. Actually, we can go back one. I'll just say a couple things about that. If you can't, you can't. There are also certain foods that, actually do contribute to reflux. And there are some doctors that'll put you on a very strict diet. I don't know if Dr. Bright is one of them. Good. So Dr. Bright is a really smart doctor. And there are, especially the ENT doctors, I see patients all the time. I can't eat this, I can't eat that, I can't drink this, I can't have ever a cup of coffee. The reality is that the disease is of the gastroesophageal junction and a hiatus hernia, period. Does coffee increase acid production? Sure. Should you drink 8 cups of coffee if you're prone to reflux? No. But if you eliminate all your coffee, your reflux isn't going to go away. If you're having 8 cups, have 1 or 2. That's my approach, kind of like Shvil Hazov approach. This is what happens when you go to yeshiva and you don't just rely on medical school. You learn some, basic tenets of, reality. So yes, there are certain foods that relax that gastroesophageal junction or increase acid production, but they are marginal compared to the underlying problem. So there's a role for food, being careful with food, but it's not the key. Now, on the other hand, lying flat in someone who has wide open reflux when they go to bed at night is a no-no. And that's because if you really have a weak valve and you lose gravity from keeping acids in the stomach, they're going to reflux right up into the esophagus. So that is a problem for some people, and therefore don't eat dinner at 11:30 at night because you're working so hard, and then go to sleep at 12. Not a good idea. It's not healthy. Okay, we go to the next one. We'll go to the next one. That's too technical. I'm not going to go to that. And we're going to go to the next one. Okay, now it's interesting that there's a better understanding today of what the cause of that gastroesophageal junction opening inappropriately is. And it has a name, and it's called, we have to make it technical so we all sound very intelligent. Transient lower esophageal sphincter relaxations, or TLESRs. Now, I could just say the gastroesophageal junction is opening at the wrong times inappropriately, or I can call it a TLESR. And that's the way it's referred to in the medical textbooks now. So there's this transient or very short-term or temporary relaxation of that valve for various reasons. That is the most common cause of reflux. So it's not someone who has no valve, or someone who's had surgery, or someone who's had damage to the valve, or someone with a big hiatus hernia. The most common cause is that the valve is no longer working properly. It's opening when it should be closed, period. Okay. Now, there are other people, that have some of these causes, and they are very important. This is the most common, and this is a very important one as well, which we're going to talk about. Okay, you can go to the next. So these inappropriate relaxations do not occur at the time of swallowing. They just occur randomly. You can go to the next one. This is like, goes in sequence. They last 10 to 20 seconds. I think he's getting it down. It's the major cause of reflux. And you can do one more. And it's thought that it's perhaps mediated by the fact that if you overstretch your stomach, you send signals to the brain and you begin having these inappropriate relaxations. And again, that goes back to our guy who's eating a hamburger and, is eating too many hamburgers. Okay, so we can go to the next one. Next. Okay. This is just to point out that the other thing about stress, as I mentioned, is that it increases these TLESRs. If you're stressed, you get a signal, the valve relaxes. You can go to the next one. And there's just a couple of things I want to say about this in case you've come across it. Does everybody know what a pH is? Remember that from high school? The pH. So pH is the way we measure if something is acidic or not acidic, or basic as we call it. And a low pH means very, very acid. Water has a pH of 7. Hydrochloric acid has a pH of 1. And lye has a pH of 11. That's a base. You know, what you put down in Drano is lye. So what happens in the stomach is we make hydrochloric acid, believe it or not, one of the most potent acids around. And the pH of the stomach can reach as low as 1 to 2 at times. And so they did studies where they can measure this pH in the stomach, and they wanted to see what happens if you get one of these TLESRs, or inappropriate relaxations. So you can hit the next one. So here you go. This is measuring the pressure. And the pressure is, they have like a pressure transducer here, and they say it's real tight, it's 40 millimeters of mercury, and then boom, it relaxes. And then watch what happens. The pH drops. So that's how they can demonstrate that these relaxations are the direct cause of a drop in pH inside the esophagus. And we can measure this, not the TLESRs, but we can actually, which I'll show you at the end of the talk, we can put a little device inside the esophagus that measures someone's pH, called a pH probe. We don't have to do it very often, and if I did it to all of Dr. Bright's patients, he'd be wondering, you know, what planet I'm on. But on occasion, we can do it, especially in a difficult case. Okay, next one.
He guys would do it if they had the chance.
Okay. All right, so we'll skip this one, we'll go to the next one. And we'll go to the next one, this is too technical. Now, hiatus hernia, that's a great topic. Everybody's heard of their grandmother having a hiatus hernia. I know my grandmother had a hiatus hernia. So that's the kind of thing you hear about. Some relative had a hiatus hernia. So what does that mean? Now remember the very nice picture we saw where the diaphragm was up here and the esophagus ended, and there was a very symmetrical connection between the lower esophageal sphincter, the internal muscle, and where the diaphragm is. Now in a hiatus hernia, the diaphragm begins to separate. So that little tiny hole in the diaphragm, which is sitting like this, begins to separate, and the stomach loses its attachments and begins to ride up through that hole in the diaphragm. So your stomach is literally in your chest cavity. So when you have a hiatus hernia, what used to be in your abdomen, we call it the stomach, what used to be in the abdomen is now going through the hole in the diaphragm, which is a hernia, and we call it a hiatus hernia. Hernia means a hole where it shouldn't be. And so the stomach is rising up through this hernia. Now this is a real excellent way to have very bad reflux if you develop this hiatus hernia. Now how do you get a hiatus hernia? Again, maybe it's obesity, genetics. There's nothing you can do. It's not from lifting a heavy suitcase or straining. Maybe it is, who knows. But, you know, we're not quite sure why some people get it and some people don't. Okay, we can go to the next one. And you can go, it's just a bunch of stars that are going to come out. And just the last thing, all right, that's it, that was fine. So one item that I didn't mention is what can happen in a hiatus hernia is all the acids that are here can get trapped in the hiatus hernia, in the part of the stomach that's above the diaphragm and below the lower esophageal sphincter. So you actually develop like a sac of acid sitting in your chest. Now it's in the stomach, so it's not going to make a hole. The stomach is very protected from acid, but it allows just a constant pool to bathe your esophagus. So if you have a hiatus hernia, you're looking at a lot more and a lot more severe reflux problems. And this is a depiction of it. So this is our acid, and this is going through the hiatus hernia into the stomach and the chest because there's really nothing to stop it. And this is the person swallowing because they begin to feel kind of yucky and they want to get the acids out. And then what happens is they can't clear the acid out of this little pocket, and then it's free to reflux at a much more frequent pace than if there was no hiatus hernia. So people with hiatus hernias do in fact have more reflux. Now, ironically, in the 1980s, we were taught that hiatus hernias don't play a role in reflux. just shows you how things evolve in medicine. So hopefully in 20 years, someone won't come talk to me and say that it plays no role again, but right now it plays a big role. That's the way it goes. Okay, we can, there are some things that I mentioned, like saliva, which is has a little bit of bicarbonate in it, which can neutralize some of the acids. And we have peristalsis to try to get rid of the acids. So we do have some protection, to get rid of these acids. And a lot of this is just to tell you, and it's much better if I just show you the picture. You go to the next one. Just to show you the difference between the stomach and the esophagus. So why can hydrochloric acid at a pH of 2 sit in the stomach to help you digest your food, and everyone doesn't get an ulcer? Now they do get an ulcer if they take Advil, aspirin, or they have H. pylori, because the stomach loses its protection. But if in the normal stomach, without any other additive piece, there's this mucus layer on top of the lining of the stomach. Underneath the mucus layer, the cells of the stomach make bicarbonate, the same old stuff like sodium bicarbonate. And so we have all this acid, which can't really get through the mucus very well, and whatever does get through gets neutralized by bicarbonate. Now, in the esophagus, unfortunately, there's no mucus layer. So there's a little bicarbonate, but if you have a lot of acid, you overwhelm the lining of the esophagus. And that is why you can have no ulcers in the stomach, no duodenal ulcer, and a whopping esophageal ulcer. Because the esophagus was not designed to protect itself from acid. That circles back to what I said about Barrett's, where you get that reddish tissue. It's actually a lining that makes mucus. So the body is trying to protect itself. Unfortunately, changes occur in the DNA, which are preludes to, potential cancer. We'll go to the next one. Looks like the video's out. They used up the whole hard drive. I'm talking too long. Okay. We can go to the next one also. This is all very technical stuff. Now, this is interesting, and even if you're not someone who looks at a microscope all day, which I'm not, you can see that this looks better than this, right? This one is kind of all messed up, it's falling apart, it's disintegrating. These are actual electron micrographs of normal esophagus tissue and esophagus tissue after acid damages it. So what we see as an ulcer under the microscope is, cells falling apart, and that's how you get the ulcer. The ulcer is actually just the body sending in white cells and things to cover up a defect. All right, we'll go to the next one. We'll go to the next one. Okay, so how does it manifest? That's always the big question. So now that you're scientists, you all understand all there is to know about why people have reflux. What actually do people experience when they reflux acids into their esophagus? So this is a pretty classic pose, although it could be a heart attack. I would probably get an EKG on this guy if I saw him, but assuming his EKG is normal, his wife, of course, has no idea that he's worried at night and getting reflux because she's peacefully sleeping, but he's not doing so well. So how does it manifest? Well, one thing is heartburn. That's what everybody knows. It's a burning, squeezing, uncomfortable feeling in the chest. All right, next one.
Next one?
Yeah. Okay. So the most common is heartburn, but then there's regurgitation, and it's important to know the difference. And then finally there's dysphagia, and these are a little bit less common. So let's talk heartburn. You know what it is. It's a burning sensation in the chest. 99% of the time, if it's, once you make sure it's not your heart, you should never assume it's reflux until you see your doctor, because very often a heart attack can feel like heartburn. So
Sorry.
that's okay. So if you feel that pain in your chest, and obviously you see someone like Dr. Bright, you make sure it's not your heart, and then he's going to try you on some medicine for reflux. Now, heartburn is different than I go to sleep at night and I wake up choking, coughing, and wheezing. Now that is not heartburn, but it is definitely reflux. It's reflux that may not be causing chest pain, but the fluids are coming so high up the esophagus that it's irritating the throat and the lungs. And so regurgitation is another very important symptom of reflux. Now, very often patients will say, well, you gave me Prilosec, and the burning went away, but, you know, I'm still waking up at night and feeling fluid in my mouth and coughing. Well, the reason is that none of these medicines, called proton pump inhibitors or acid blockers or H2 blockers like Zantac or Pepsid or whatever you buy over the counter, none of them fix the valve. They fix the amount of acid in the fluid that's coming up. So while you may eliminate the burning because there's not a lot of hydrochloric acid anymore, what you're not eliminating is the fact that you have an incompetent valve and fluids coming up and choking. So what do you do with someone, and you know, we can get to the slides later, but what do you do with someone who has a big hiatus hernia, wide open reflux, and they're choking all the time? And you give them omeprazole, and you do this, and you do that, and they're really not feeling better. Well, then some people actually have to be considered for surgery. So, and we can, you know, if we get to the slides later, you'll see that there are some alternatives to taking these medicines.
Give it a
And we'll get into place.
I already see what it takes me to really foul up things.
Yeah, I know you're posting this video, so I'm just going to tell you this is why I use a Mac.
I hate Macs.
No worries, Steve.
No, he's in charge. He can say whatever he wants. All right, so this is a good time to stop for a second. Does anybody have any questions? Yes?
Person who has H. pylori and gets rid of it, can it come back?
No,
It cannot come back.
no. Doesn't happen.
Because I had H. pylori, I took the dose and it went away, and I still have the heartburn.
So that's a very good question. So you have to distinguish between the symptoms of H. pylori and the symptoms of reflux. So H. pylori is an infection in the stomach that gives...
No, it's not yet. It's way yet.
H. pylori gives nausea, queasy feeling, bad breath, burping, maybe a hollow feeling in the pit of your stomach, hunger pain, and also can cause ulcers. Heartburn is something that causes, you know, comes from acids coming up and burning your esophagus.
Excuse me 1 second.
Yeah.
I'm almost there.
Keep going. Keep going. Keep going. Go. More. Good. Now, in fact, one of the things that we know, which we mentioned before, is that you can treat H. pylori and make heartburn worse. Because maybe you have a minor incompetence to your valve, but you had H. pylori and you're not making all that much acid because your stomach is a little sick. Now you cure your stomach feels great, it makes twice as much acid. Now that little bit of incompetency in the valve is allowing you to have heartburn. So if you go back and say, you know, I don't think you fixed my H. pylori because now I have heartburn, it's exactly the opposite. I fixed your H. pylori and I gave you heartburn. So now you have to treat the heartburn. And we don't have a good solution to that because you have to fix the H. pylori. There's too much risk in having H. pylori. So the correct thing is to fix it, but then deal with the heartburn as a separate issue. So they're related, but they're not the same.
Is it dangerous as H. pylori or no?
Which? Heartburn? It can be. You know, I have to say the vast majority of people have heartburn and they're fine, but the only way you would know is to get checked. You know, I can't look at you and say, oh, that's a very nice person, I'm sure her heartburn isn't doing any damage. I can't see inside your body. So we're very lucky in our current age. We want to look inside the body. We put a camera in, we look. You know, it's a fantastic thing what we can do today.
Question?
Yeah.
Are there any foods like, they say, milk or Tums that neutralizes the acid?
That's a great question. That's such a good question because it reminds me to tell you something that's very interesting. So perhaps when Dr. Bright was a medical student, I don't know, maybe. When people had ulcers, I don't know what year you were a medical student. Cream drips?
No.
1800. Yeah, I was after that.
Okay. So in
Milk and mail.
at Maylon. So before Dr. Bright was a medical student, and a little bit before I was a medical student, when people had ulcers and burning or reflux or whatever it was that was bothering them, they would drip cream in, saying, oh wow, once you put cream in, it neutralizes the acid and your stomach has to digest it and you feel much better. And if you used to watch Get Smart, anybody used to watch Get Smart?
Yeah.
Maxwell Smart, the chief always was drinking buttermilk. Remember that? That's how I grew up, was watching Get Smart. So, what actually happens, it's very complex. Yes, when you drink the buttermilk, you feel better for about 10 minutes. However, you're stimulating even more acid than you had before you drank the buttermilk to digest the buttermilk. So as soon as the buttermilk is gone, now you have even more acid than you had before, and we were actually making people worse. Then Maalox came along, which isn't buttermilk. It doesn't stimulate acid production. So there is no food that will cure an ulcer or reflux. Doesn't exist. It's too complicated. But remember, the stomach reacts to food by producing more acid. So your acid's here, you have an ice cream cone, your acid's here, but you don't feel it because it's mixed up with all the ice cream gets digested, and then all you have is a lot of acid. That's why if you eat a heavy meal, you have more reflux. The heavier the meal, the more acid you make, the more chance there is to reflux. Okay? Does that answer the question? Sort of? You're not happy with it?
I've taken, for example, Tums, and I find it worse afterwards. The reaction,
And the Tums should help for about 10 minutes, 20 minutes. So that's the other thing about Tums and Maalox. They will neutralize acid for minutes. If you want to really neutralize acid, you have to take a drug that tells the stomach to stop making acid for a while, or at least to make less. So Zantac and Pepsid tell the stomach, cut down your acid production by 50%, and Prilosec and Nexium tell the stomach, stop producing 60 or 70% of your acid.
And Promacid?
Same, they're all relatively the same. I think some work better than others. The insurance industry doesn't think anyone is better than the others, but I won't give you my bias, but there's one that works better than the others. Yes, in the back.
What's your view on natural remedies instead of paying the drug companies so much money for all this?
It would be great if someone had a natural remedy that's been proven to work. So I'm in favor of any natural remedy that's been scientifically proven to work. The problem, let me just finish and then I'll let you talk. The problem with natural remedies is that it's what we call in medicine anecdotal. And anecdotal means that, my Uncle Jack took cucumber distillate and his reflux is gone. And I'm telling you, if you take cucumbers and put them in a blender, your reflux will go away. Now, it could be that Uncle Jack felt better, but if you take 1,000 people and give them the cucumber distillate, they're not going to get better. It could be an anecdotal or an individual reaction to something. So us doctors, Dr. Bright and I, and people who are involved in science, what we rely on is data collection. So we do studies on people and we say, I want to give 500 people the cucumbers and 500 people the Prilosec. They all have the same amount of reflux, and then I want to scope them and see whose ulcers are gone. And then if you can show me that the cucumbers work as well as the Prilosec, I'm going to start prescribing cucumbers.
But then why don't the pharmaceuticals do that research? I mean, Eastern medicine has been around for thousands of years. There must be something to it.
There are some Eastern medicines that actually have drugs in them. And it would be great if we can identify which ones work.
Why won't they do the tests?
You know what? A lot of drugs are discovered by going into the rainforest and looking for chemicals in various plants and trees. It's not true. A lot of drugs come from nature. You just have to find them. You have to find them. So if you identify one, sell it to Pfizer for $50 million. Yeah.
I'll put a plug in for licorice, which will solve the problem, except you'll die of lack of potassium in your body.
I've had patients who say licorice works. Yeah.
What about using water with a pH, drinking water with a pH of like 8 or 8.5?
So that's what an antacid does. That's what Maalox and Tums do. They're going to neutralize acid. The problem is that it'll be out of your stomach in 20 minutes.
Well, the thing about water is you can drink it every 15 minutes and it's absorbed
That,
quickly.
okay, that you can do. That's a lot of water. And you can also just keep swallowing Tums, but you'll get kidney stones, or if you keep drinking Maalox, you get too much aluminum in you. There's no simple solution that all us doctors forgot to think about. You know, there's no reason why we wouldn't want the safest, simplest solution. None of us are on the payroll from a drug company. You know, unless we do research for them or speak to them on occasion. Even that, it's not, that, you know, very few doctors are going to push, at least the ones that I like, are going to push drugs for no reason. So, you know, when your doctor says you should take this drug, I don't think they're getting some benefit from it other than they think they're helping you.
Is there a danger to taking these drugs long-term?
Yes, there are. So, like all things in medicine, what you think you know today, you don't know tomorrow, and things change. So, in the late 1980s and 90s, there was a little bit of a concern that if you gave these proton pump inhibitors to people long-term, like Prilosec, Nexium, that it would be dangerous because when they tested these drugs in rats, they got a rare tumor called carcinoid. So we used to not give them. Then, fortunately or unfortunately, we found out that humans don't get carcinoids from taking Prilosec. They can take it for 20 years. So people just started using it very freely. Then we found out that, okay, you're not getting carcinoids, you're not getting cancer as far as we know, but you're predisposing people to certain infections in the intestine, decreasing their iron absorption and decreasing their calcium absorption. So it's not a free ride. So you have to balance using that drug, which is very effective, to using a less effective drug like Pepcid or Zantac, which doesn't have those side effects, to doing surgery to tighten up the valve, or losing 100 pounds and hoping that your reflux gets better from weight loss. So no, these are not a free ride, these drugs, and the latest trend is to try not to use them unless you have to. So you're correct.
Is there a difference between Nexium and Prilosec? Because the insurance companies will not pay for Nexium.
So their calculation in which ones to pay for, and it depends which insurance company. So basically what happens is, let's say you have Aetna.
Blue Cross.
Blue Cross. Blue Cross is going to go to Express Scripts and say, we're going to give you $10 million to give all the drugs you need to all our patients. Express Scripts is going to then go to the makers of Prilosec and Nexium and say, how much are you going to charge me for Prilosec? And this guy says, I'm going to charge you $2. And then they go to Nexium and they say, well, we'll charge you $1.80. So guess what? You're not getting Prilosec, you're only getting Nexium. These were all negotiations behind the scenes between the pharmaceutical houses and the, between the Express Scripts type people and the pharmaceutical business.
Well, I got a letter from Blue Cross with a host of drugs they're not going to cover, and one of them is Nexium.
It's all about contracts and money. It's not because they think one is better than the other. Now, if you can prove to them that you really must take one particular drug that's not on their formulary, then they'll let you buy it. But I have to tell you, if you go to a doctor and say, can you get this pre-authorized? It's a joke. So they want to have documentation that you took every other drug for 30 days and came into the doctor's office complaining of symptoms. And if you don't have the paperwork, they won't approve it. So if I call up and say, listen, my patient, Mr. Jones, was doing great on Nexium, now it's not approved, and you're giving him Prilosec, he doesn't like Prilosec, they're going to say, so.
It's terrible.
That's the way it goes.
It's terrible.
That's the way it goes. I don't have a good answer for you. I don't run all that stuff. Yeah.
Just perhaps a concern, long-term, maintaining the pH, aren't you changing the flora?
Yes.
And,
Yes. So there are, so amazingly, so there's a couple of things to say about that. Years ago, there were a lot of operations for ulcer disease. I don't know if you remember those days, but even when I was training, there were a lot more operations to treat chronic ulcers before we were getting rid of H. pylori. When you treat an ulcer, you eliminate the body's ability to make acid. That's first of all. So lots of people for decades have been working on that acid. The other thing is that certain forms of gastritis, stomach irritation, you don't make acid. So there are a whole other group of people that don't make acid because their stomachs don't work real well. Now, most of these people do okay, just like you do okay without your gallbladder, and you do okay without your appendix. It's not ideal, and yes, it changes some of the flora, but for most people, it doesn't lead to disease. If you're going to go out and eat sushi and you're taking Nexium or Prilosec, I think it's a little risky. The other thing is Clostridium difficile, which we'll have to do another night. Turns out you have more of a chance of acquiring that intestinal infection if you're on Prilosec. If you travel to a third world country and you drink bad water and you're on Prilosec, there's more of a chance that you're going to get an infection. But the flora in the gut doesn't seem to change that much that you're predisposed to any known diseases in a wide scale. So yes, it's a problem, but not a gigantic problem. Okay, does that answer? Fair? Oh.
Did you say how you treat H. pylori?
With antibiotics. And, yeah, you have to treat it with antibiotics, or maybe licorice, I don't know.
Tastes better.
Yes.
Probiotics? Do they do anything?
So probiotics, this is a whole fascinating field, probiotics. And there are some probiotics that are very helpful for some conditions. And we're not quite there yet in understanding which ones work for who. That's the best answer. So if you're taking an antibiotic and you don't want to get Clostridium difficile or diarrhea related to killing off the normal flora, a probiotic is an excellent idea. If you have Crohn's disease, and you heard from, again, Uncle Jack, that if you have Crohn's disease and you take a probiotic, your Crohn's disease goes away, it's like rolling dice. Because we really don't know which organisms are really necessary to keep you healthy. Now, having said that, we now understand a little bit more about the normal flora in the gut. It plays a very big role in health and in illness, which I guess is what you were alluding to. So lots of allergic illnesses, autoimmune illnesses may be related to different flora inside the gut. But we're just beginning to learn it, and we don't know enough yet for people to make very firm, concrete recommendations. Take a line or VSL3 and you're going to live forever and never get arthritis. We just don't know enough yet, but we're starting to learn. Now, on the other hand, if you have Clostridium difficile, which is a really great topic for another night, maybe next year. Clostridium difficile is a very bad infection you get from taking antibiotics because all the normal flora is killed. And so when the normal flora is killed, Clostridium difficile takes up residence in the colon and makes you very ill. So that's an example of getting rid of the normal flora and causing yourself major harm. So it's a real issue. Yeah.
What about a fecal transplant?
So that is used in Clostridium difficile, and there's just some studies only in the last couple of years. Now, hopefully, my bias, okay, will figure out which bacteria we need, and someone will put it in a capsule, because the idea of doing a stool transplant is, very complicated. Very complicated. It has to be a close relative so that you're not passing along infections. Lots of infections are passed in stool. Hepatitis, CMV, all kinds of viruses. You do not want to get a stool transplant from anybody unless you are living with them or married to them, and you've already shared all your germs. But so it has to be a very carefully screened person, and it's taught us a lot. And I think the future is identifying which bacteria we should isolate, put it into some type of capsule that makes it to the colon, and repopulate the colon with the bacteria without having someone's stool.
But would that do anything for GERD?
No. Is it both?
How would you distinguish between this and what's called IBS?
GERD?
Yeah.
So, IBS is a catch-all phrase, which seems to refer more to what goes on in your intestines as opposed to your stomach and esophagus. So an IBS symptom would be crampy abdominal pain, urge to run to the bathroom as if you have diarrhea all the time, or the opposite, never go to the bathroom, or lots of gas and bloating. Your stomach swells out to here, and you feel like you ate 10 portions of cholent. So IBS refers more to abnormalities of the intestine, which there's 20 feet of small intestine and there's 6 feet of large intestine, the colon, and IBS more often refers to that. We say stomach, we think it's like one big black box in here, but there's esophagus, stomach, small intestine, colon, and IBS is more the symptoms related to the colon and intestine. Okay? GERD is related to the esophagus and the upper stomach.
Can one be confused which it is when experiencing it, or is it easy?
If you have a burning pain here, it's not IBS. If you have lower abdominal crampy pain and you're running to the bathroom when you have to take a test, it's IBS. If you have just vague abdominal discomfort, it's probably more IBS. GERD is very specific. And a lot of problems are occurring because doctors are too quick to call everything they see in their office GERD. Now, I'm talking about gastroenterologists. So, oh, your stomach hurts? It's GERD, take a Prilosec. They don't even stop to listen what's really bothering someone. If you stop to listen and think about it, it sounds like more of an intestinal problem. So a good gastroenterologist or an internist should be able to distinguish between GERD symptoms and IBS symptoms. Now, IBS is not something that you throw around in an adult. You know, if an adult has symptoms, it's not IBS. It's only IBS after they've gone through a whole bunch of tests and you can't find anything. So if someone is 16 and says, and they're in your class in SAR, and you're giving them a big test on Tuesday, and Monday night they can't sleep and they're having like a little bit of the runs, it's probably IBS. If someone is 52, starts getting crampy abdominal pain, gas and bloating, they need to be evaluated. It's not IBS. It could be diverticulitis, it could be 100 other things, an infection. Okay? All right, so I think we'll just answer a few more questions. Dr. Bright, what do you say?
People have them.
All right, we'll do three more questions? All right. You're in the back the whole time. Oh, you're raising your hand, so you go first.
Two questions. Like these Tums or Maalox or anything, are they just good for every so often if you feel like heartburn?
It's an excellent question. So lots of people get occasional heartburn. They don't need to be on Prilosec. So if you get heartburn once in 2 months, only because you ate too much or you're under stress, or take a little Maalox or even a Zantac and call it a day. This is for people who feel it all the time, or 5 times a week, or 20 times a month. Those are the people that need to be treated. And they either get treated with the H2 blockers, the proton pump inhibitors, or we didn't really get to it in the talk, or a surgical repair of their hiatus hernia. But occasional heartburn is not a reason to take a strong medicine.
Second question, in strong medicine, you say you would see in longer. Doesn't it decrease your ability to digest food because you're reducing the acid in the acid?
You would think, but it doesn't. So we have a redundant system of digestion. And digestion starts in the mouth with saliva. And then, starts going, there's a lot of digestion that occurs in the stomach with acid and pepsin. It breaks down proteins. Most of the digestion occurs in the intestine from the enzymes that are either coming from the pancreas or from the lining of the intestine. And although it must be healthier in some way to start your digestion the way it was meant to start, the way God made us, you can get away without the stomach. You can take people's stomachs out and feed them straight into their intestine, and they still digest food. So there's a lot of redundancy in our ability to digest food. It's like a fail-safe system. Okay, your stomach's not working, you still have your intestines. Can't lose both. Okay. In the back? You wanted to add something?
I didn't think you mentioned that.
Something that's hard to digest. You've had bread, and then you have to throw up. Your throat chokes a bit.
Feel like what my daughter said that she gets this feeling when she feels like she can't breathe for like a couple of seconds, and then it sort of comes out after she eats something.
Or she'll throw up. Once every couple of years.
She may be refluxing, it has to be evaluated. So sometimes you can hear a symptom and you know right away what the cause is. And, Dr. Bright can tell you that. He can be sitting behind his desk, you tell him what's wrong, and in 2 seconds he knows what's wrong with you, from experience and from training. Sometimes the symptom is a little bit harder to figure out, and it requires some more careful testing. So for something like that, I would not know off the bat 100% what it was, and I would look into it. Is it the lung? Is it stress? Is it reflux? Is it neither of the above?
Is that something you think that you look at that's your area?
Sure. I'll be happy to.
How does wine affect Laura's activity? Drinking wine?
It makes you feel much better. Too much of anything is no good. So I would never tell someone to not drink wine. I mean, if you have an ulcer, if you have an active ulcer, it's gonna hurt. If you don't have an ulcer and you're well controlled and you're on the proper medicine, then you can have wine. I mean, don't drink a bottle of wine, you know, I mean, it's a lot. But I don't, you know, like I said, I don't restrict people. You know, too much wine isn't good. Cigarettes are terrible. They're the worst. I don't know if anybody still smokes. Cigars, terrible, terrible. Tobacco is terrible. Wine is not ideal, but there are many benefits. So you don't want to give everything up. What, anything on wine?
Excellent, I didn't hear you
I
mention
think she had one more question also. What's that?
excellent.
So, you know, drug companies are in the business of making a lot of money, so they, you know, omeprazole was the first proton pump inhibitor. And then all the drug companies said there's billions of dollars in these drugs. These are the most commonly prescribed drugs in the world. So there's a lot of money there. Dexilant is a reformulation of Prevacid that lasts longer. So if the drug person says, oh, this is the greatest thing for reflux ever, it's as great as all the others if it works well. It's a good drug. I tend not to use it, but you know, I don't find that people get that good relief from it. But that's an anecdote. I don't know what I was saying about anecdotes before. That's anecdotal. So there's no paper that says that Nexium is better than Dexilant. In my years of treating people, I don't find Dexilant to be my favorite drug. But if you feel on Dexilant it's working, I'm not going to change it. You know, let you keep taking it. Yes.
One last question. Person who has indigestion, can he also have a problem with heartburn, or is it?
So indigestion is an interesting term. Heartburn is a very specific term. It's burning.
Right.
Indigestion is, I don't feel right, I ate too much, I'm too full, I'm burpy.
So you could have indigestion without the heartburn?
Indigestion could be a lot of things. Indigestion could be H. pylori. Indigestion could be an ulcer. Indigestion could be gallstones that aren't bothering you too much. Indigestion could be an intestinal infection. Indigestion could be Crohn's disease. Indigestion is such a vague symptom that you have to really evaluate. Heartburn is heartburn. It's, as long as it's not the heart, it's heartburn. Yes?
In fact, in the early part of the 20th century, 1900s, 1910s, indigestion was listed on death certificates, was one of the 5 leading causes of death. Those are obviously all heart attacks.
That's very
Somebody says, it's fact.
interesting.
Somebody says they have indigestion, go to the ER.
Yeah. Indigestion has to be evaluated because it means so many different things to so many different people. And women in particular, referring to what Dr. Bright just mentioned, very often when they're having heart attacks, they experience it like indigestion. Men, not so much, not as much as women, but indigestion for a woman, if they're in the right age and the right, risk group, they smoke, they have a family history, they're postmenopausal, indigestion is worse. Okay? Oh, yes.
Just looking at the third line, where it said the exercise word is jumping. Does that have anything to do with exercise come into this at all?
Well, this is talking about spasm or non-cardiac chest pain. So this is, ignore that.
Oh.
It's not about heartburn. We'll leave that one off. So that's people who have atypical chest pain, which can be a manifestation of GERD, and it's misleading. It's not, we should take this off. The next time I give this talk, that's going off. I'm not going to put it on. Very good. You're helping me with my slides. Okay? All right, listen, thank you very much. It's very enjoyable.
Thank you.